It is common to administer antithrombotic drugs to patients with NSTEMI prior to coronary angiography. A paper in the December 20th issue of JACC discusses bleeding events before coronary angiography in patients with non-STEMI. And this is Dr. Philippe Genereux, who is director of the Angiographic Core Laboratory at the Cardiovascular Research Foundation and also an interventional cardiologist up in Canada, in Montreal, actually. This is really quite a paper because you realize that you have to give these people these drugs, and the whole concept of wonder what the bleeding is just when you're doing that before angiography. So what did you learn? I love the paper concept.
Yeah. So this idea came when I was on call a weekend, and there's a lot of patients with non-STEMI during the week or come with unstable angina, and we hospitalize them, and we give them aspirin, clopidogrel or ticagrelor, heparin, and then they're waiting for the angiogram. And it's not infrequent that these patients are bleeding while awaiting their angiogram. So I think my question was, is there a way to look at what is the rate first of bleeding while waiting the angiogram? And we can look per indication. And the second one is there a way maybe we can accelerate the angiogram on some patients that are more at high risk of bleeding, and you don't want to leave these guys, these patients on 3, 4, or 5 days of antiplatelet therapy, but also antithrombotic drug, heparin or 2B3A. So, and it's a common problem when you have patients with non-STEMI, for example, and then you put aspirin, heparin, 2B3A, and so on, and you load them with a lot of antiplatelet therapy, and you wait. So the goal was really to demonstrate that maybe to go to the cath lab faster, quicker, with less drug will be beneficial, and then you take a decision on the spot. So what we found actually was interesting is the longer you wait, no surprise, the more bleeding event you have. And when you take major and minor bleeding, it's up to 10% after 4 days. So it's not uncommon that you have a patient, for example, coming in with a non-STEMI on Thursday, and you're going to do the PCI on Monday only. Actually in certain geographies, such as Canada. So the longer you wait, the more actual bleeding you have. If you actually have 2 drugs, 3 drugs, the use of a 2B3A, or even like 2 antiplatelet therapy is also increase your risk of bleeding. If you're old and you're a woman, also you increase your risk of bleeding. So the goal is really, and actually bleeding increase mortality by 2-fold.
Right.
So I think this is the concept of, if you have an indication of an angiogram, why wait that long? And why accumulate the antiplatelet therapy and the 2B3A while you could go to the angiogram rapidly and actually find out what is the problem? And surprisingly, a lot of these patients had no coronary disease. It was another origin of the chest pain. It was troponin elevation from another cause, myocarditis. Right. So you expose these patients to a lot of cocktails of drugs with no benefit. And we look actually at the rate of MI while waiting and the rate of bleeding, and actually the rate of bleeding was higher than the rate of MI, and in fact the patient, the mortality was higher with bleeder than MI patient.
How many patients did you look at?
So we look at the acuity trial.
Okay.
It's a large data set, around 10,000 patients. So it's an extremely large data set. So that's the reason why we have the Coronary, the power to detect such bleeding event.
Right. So is this going to change anything in the way you do, or at least the way you recommend that people handle patients?
So I think the way to see that is, if you think that you should go to an angiogram with a patient with a non-STEMI or active chest pain, I think you should go as soon as possible. There's no emergency here to go within an hour or at 3 a.m. in the morning, but to minimize the length of exposure to 2B3A or dual antiplatelet therapy before. If you go faster, well, you will be able to load on the table, or you will be able to use other novel drugs such as cangrelor. So I think that was the goal. I think in 2016, if we use a more contemporary approach where you give aspirin, you can give a little bit of heparin, and then you go to the cath lab quickly, no 2B3 upstream, and no antiplatelet therapy, no P2Y12 inhibitor, and then you take an angiogram. Now you can decide. You give cangrelor, you give ticagrelor, clopidogrel, and then you take the decision. If you go to surgery, you're not compromised. So I think that was the philosophy, to see, well, don't wait too long with drug on board that make you bleed.
Right.
Go to the angiogram quickly to A, have a good diagnosis quickly, and B, to take a rapid decision and to give antiplatelet therapy and antithrombotic therapy to patients that deserve to have them, or send to surgery with no increased risk of bleeding. So I think this is just to raise awareness that to upfront load people with 3 drugs, 4 drugs while they're waiting, especially in an old patient with renal insufficiency, it might not be the best idea. And the answer is maybe to go to the cath lab quickly to have the reality and a real diagnosis, and then.
And if someone is going to be delayed a little bit, is it a good time to get a bleeding risk score?
Mm-hmm. Well, yes, so there's a factor that we're associated with the delay angiogram and increased risk of bleeding, renal insufficiency, prior CABG, woman age. I think it's difficult to have a bleeding score because the rate of bleeding was quite low. Major bleeding was 1 to 2%. That being said, it's a common sense. I think when you have renal insufficiency, when you're older, when you have small body weight, and you have so it's really common sense. So yes, we could develop a risk score, but again, the risk score sometimes blur your judgment more than it's helping.
Right.
I think the key here is to avoid the multiple antiplatelet therapy that are unnecessary, and to go to the angiogram quickly to have a real snapshot of the reality.
Well, this is really a large analysis, and it is a great paper, so please take a look. It's in the December 20th issue of JACC. And for CardioSource World News, I'm Executive Editor Rick McGuire.